if we hear in the history that there was a trauma, then of course we also have to consider extra diagnostic options, such as a capsuloligamentus problem, muscular problem, a facet joint problem. Well, let's have a closer look. For instance, a local muscular problem mostly is in combination with a lesion of the high cervical capsuloligamentus structures, because you don't get a muscular lesion by just doing normal activities. You need a trauma. And if there is a muscular lesion, so mostly it's the insertion of the semispinalis capitis. And what do you find in your clinical examination? Well, resisted extension and homolateral side flexion are clearly the main positive tests. The good news is this reacts very good and very fast on friction massage. But talking about high cervical capsuloligamentus lesion, actually we talk about a kind of dysfunction syndrome, as I also described in the lumbar spine chapter. Let's imagine there was a trauma followed by immobilization, or let's say not enough movement, resulting in a kind of chronic lesion, because you get capsuloligamentus adhesions. And what you find in your examination, well, you get end range pain on several movements, extension, rotation, side flexion, and of course repeated test movements don't cause any change. When you repeat it 20 times, the same end range pain, it doesn't get worse, it doesn't get better. And after repeating 20 times, what do you feel now? It's not better, it's not worse, no change. Well, actually, such a situation might react very good on what we call the quick stretch manipulation. We do manipulation in rotation and a manipulation in side flexion, but both rotations and both side flexions. So you do 4 manipulations, and of course the patient has to move at home regularly end range. Perhaps you can give him a belt or so to help him to do a kind of auto mobilization. Little detail: if the patient has an internal derangement, don't do this, because those are maneuvers without traction. If the patient has vertigo, don't do this. Well, we can also do this maneuver not as a manipulation, but as a, let's say, a slow capsular stretch. Well, the manipulation you're going to do in the kind of dysfunction syndrome or early arthrosis, the rather slow stretch. You go to the end of the movement, you stay there for about 30 seconds, you come back and you stretch again. I refer to the practical films. Well, this is something you can do in case of an ankylosing spondylitis, if it's symptomatic, and advanced arthrosis. Facet joint lesion. Well, we talked about this also intensively in the lumbar spine and came to the conclusion that a real facet joint lesion in the lumbar spine is not so frequent. What about the cervical spine? Well, keep in mind that you can exclude a facet problem if the patient is describing central pain, because you know that a unilateral structure only causes unilateral pain, so it can't cause pain on the midline. You won't have shifting pain. You won't have alternating unilateral pain, also a kind of shifting pain. You won't have pain on cuffing. And you won't have radiation of pain into the arm. So, if you exclude that, then perhaps there could be a facet problem. And this is a nice picture to illustrate the maximal referred pain pattern if there's a problem with facet joints. So as you clearly see, there is no radiation of pain in the arm. Yeah, manual examination to identify the facet joint as the primary source of pain. So here we go again. Don't overestimate our palpation skills. Many people seem to be able to feel things which actually you can't feel. And I discussed that extensively in the lumbar spine chapter. Well, here in the cervical spine, it's a little bit similar. The diagnostic accuracy and reliability of this kind of testing is very variable. And giving anesthetic joint blocks in the facet joints seem to have false positive rates up to 63%. I refer to the lecture on sacroiliac joint. There you saw some similar numbers. Yeah? The standard was double joint injections. In other studies, they talk about false positive responses up to 27%. But other studies say facet joint pain in up to 67% of the patients. Whoa, that's a lot. Okay, if there is a facet problem, mostly it's high cervical, C2, C3, C3, C4. The patient is describing slight constant pain, unilateral, not too much radiation, no history of internal derangement. Yeah. And what can we do with it? Well, we can do this slow stretch maneuver in rotation and side flexion. We can also do a friction technique, which sometimes is really very useful. If you have doubts, is it an internal derangement or is it a facet problem? You can do kind of diagnostic friction massage, and after 5 minutes you retest. And if the patient then says, oh, the rotation is clearly better, yeah, then perhaps you have a link. But it's not so frequent. Although we just saw a reference that it might be pretty frequent, but later on is going to be clear that it is not so frequent. Intra-articular injection is also an option. 200 patients with chronic neck pain or headache, facet joint problem up to 71% of the cases. Wow! 310 patients. And actually in this study they showed that very often there is a combined problem. There could be an internal derangement problem and a facet joint problem at the same time. And this is a difference with the lumbar spine. Yeah? Facet joint problems in the cervical spine are more frequent than in the lumbar spine. But the main conclusion is that facet joint pain is very common in chronic neck patients involved in trauma. And this is the key element. If there was no trauma, real facet joint problems are very, very rare. Yeah? So they have pain as the result of adhesions and kind of dysfunction syndrome. Yeah. So it's important to realize that this is a very particular subgroup of patients. Trauma is the element. Well, and talking about whiplash, what can happen during whiplash? Well, if there is a hyperextension phase, well, a lot of things can happen. Ligamentous rupture, spinal cord compression, posterior fracture. The flexion phase, well, you don't need a lot of imagination to see that you can have a major disc protrusion. Yeah. Of course, after trauma, when you're not sure, you're going to take medical imaging to exclude, of course, a fracture. Yeah, but I come back to the interpretation of the functional examination. If you would find a muscular pattern, remember from another lecture, muscular pattern could point in the direction of a fracture. So actually most of the whiplash patients, their main problem is a big posterocentral internal derangement. And you know from the indications and contraindications of manipulation that with central protrusions we are not going to do rotation manipulation. Yeah, and certainly not a full rotation manipulation. And there are numerous studies which show that after whiplash, disc problem is quite popular. And as I mentioned in another lecture, as long as there are no contraindications, please reduce as soon as you can to avoid chronic problems in the future. So, chronic cervical facet joint pain is pretty common in the post-traumatic group. Okay? And what about headache? Well, you could have segmental headache, you could have multi-segmental headache. Well, the segmental headache, more specifically occipital headache, could be the result of such a dysfunction syndrome, a high cervical dysfunction syndrome. Could be related also with capsuloligamentous adhesions at higher age, but it could also be related with an internal derangement resulting in multi-segmental pain. But of course, there are also numerous other reasons for headache. And to conclude, I also refer to your assessment form, which you can download in the online masterclass. On each assessment form of the spine, there is a summary of the red flags. And I do that on purpose to make sure that you can't miss the red flags. Okay? One single red flag, that's not so important. But if you find a combination of red flags, then you really have to be aware and go for further examination. Safety first.